Very much so. I'm reviewing an article from JOS with regards to the diagnosis and treatment of acute Achilles tendon ruptures. Basically, they have looked through all the evidence and systematic reviews with regards to the diagnosis and treatment of Achilles tendon ruptures and put forth a series of 16 recommendations made on the available evidence. Unfortunately, they have said that a lot of the evidence isn't strong. In fact, none of the evidence is strong, and most of the issues were they were unable to give recommendations. 4 had weak evidence supporting the recommendations, and only 2 had moderate evidence to support their recommendations. So they've defined what they each of their recommendations. They've defined whether it's moderate or weak and so forth. Moderate they've defined as level 2 or 3 evidence from more than one study with consistent findings, or level 1 evidence from a single study. A classification of weak that JOS gave level 4 or 5 evidence from more than one study with consistent findings, or 1 level 2 or 3 study. Inconclusive, they said if there's conflicting or insufficient evidence, then they've given a recommendation that's inconclusive. And if there's no supporting evidence, but they think that there's a recommendation to be made just based on clinical opinion, then they've made that a consensus statement. So their first recommendation is that a detailed history and examination should be performed, and that the physical examination should involve 2 or more of the following: Thompson's and Simmons test, checking for decreased ankle plantar flexion, presence of a palpable gap, and increased passive ankle dorsiflexion, or the Mathley's test. This was based on, and this was seen as a consensus statement with very little evidence to support it. However, an obvious conclusion. It was based on 1 level 5 study that looked at palpable gap, Thompson's test, calf squeeze, Mathley's test, Copeland and O'Brien's test, which I'll go into in a sec, which was a level 5 study and was based on looking at 174 patients with Achilles ruptures. So the palpable gap, all self-explanatory, palpating the gap in the tendon. Simmons-Thompson test, the calf is squeezed, the tendon is intact, then plantar flexion occurs. No plantar flexion if it isn't intact. The Mathley's test, the knees are flexed to 90 degrees, and if the foot on the affected side falls into neutral or dorsiflexion, is indicative of a tendon rupture. Copeland test is where a sphygmomanometer is placed around the calf, inflated to 100 millimeters of mercury, and if when the ankle is dorsiflex, the pressure rises to about 35 to 60 millimeters of mercury, or rises by 35 to 60 millimeters of mercury. And if it's torn, there's very little or no pressure rise seen. O'Brien's test is when you place a small needle at right angles into the Achilles tendon, and then dorsiflex and plantar flex the ankle. And basically, if it moves, then it indicates that the Achilles tendon is intact distal to the needle. So the study that they referred to, they said at least 2 tests were positive for each confirmed Achilles rupture, and the reported sensitivities of each of the tests were quite high. Palpable gap was the lowest, 73%. Simmons test, 96%, was the highest, and this is all on awake patients, apart from the O'Brien's test. Mathley's test, 88%, Copeland's test, 78%, and the O'Brien's test, when with the patient anaesthetised, had a sensitivity of 80%. The second recommendation was regards with imaging for diagnosis. They couldn't find any studies to support the routine use of MRI or X-ray, but they found 2 studies with regards to ultrasound, which had unreliable data and didn't report any sensitivities or specificities. So they couldn't conclude either way. Non-operative management with casting. They've said that that's an option for patients with acute Achilles tendon rupture. It's addressed by 4 level 2 studies. 2 studies found a significantly better functional outcomes at 2, 3 and 6 months, but then 2 studies found no significant difference in pain between operative and non-operative management. 3 studies reported no difference in time to return to work, and 3 studies investigated return to sports. 2 found in favour of surgical repair rather than non-operative management. Found a re-rupture rate lower in surgically repaired tendons, 5% versus 12.5%, and an increased return to the same level of sport. The second study found a vastly less re-rupture rate in those with operative management, and the third study found by Metz et al. Found no significant difference in sport rates, a return to sport rates or re-rupture. Overall, the studies that the JOS reviewers looked at found no difference in extreme tendon lengthening, DVT, or any other major complications between the groups, and minor complications were usually related to the surgery, therefore they were higher in the operative group. So in conclusion, with non-operative management, they said it's an option, but the evidence for it is weak. In regards to functional bracing, as their 4th recommendation, they've said that they can't recommend for and against functional bracing, only addressed by 1 level 2 and 1 level 4 study with regards to looking at re-rupture rates, and they found no difference. The level 5 study looked at the rates of pain, stiffness and weakness, and found that there was no pain in 78% of patients with functional bracing, no stiffness in 55%, no weakness in 56%, 98% returned to full employment, but only 37% returned to the same level of sport at between 2 and 9 years. So this was seen by the reviewers as being inconclusive to recommend one way or the other. Surgical repair, they've said, is an option, again, with patients with acute Achilles tendon ruptures, and it's addressed by a systematic review, which includes 8 level 4 studies. Again, they've said there's a wide variety of patient-oriented outcome measures, a wide variety of follow-up, and it's difficult to make comparison between groups. And so they've deemed that evidence for surgical repair is also weak. They've said that they can't give recommendations again with regards to pre-surgical immobilisation or restricted weight bearing because there's no published studies, and so again they've said that they cannot conclude one way or another. They looked at surgical techniques, and they said open, limited open, and percutaneous techniques were all options for treating patients operatively with acute Achilles tendon ruptures. And open they've defined as a procedure that with extended exposure, allowing visualisation of the whole rupture and tendon, and directly placing sutures under direct vision. A limited open uses a small incision for exposure, only visualising the ruptured ends, and a percutaneous technique is one without direct exposure of the tendon rupture site. And they've said the recommendation for using any particular one over the other is weak. There have been studies that compared percutaneous versus open techniques. There's 2 level 1 studies. They did find that SF12 scores were significantly better with percutaneous repair compared to open, but there's no difference in return to function, return to ADLs or patient satisfaction, and no difference in re-rupture rate. There was also no difference in serial nerve injuries, hypertonic or keloid scars, no difference in deep infections, but 2 out of 3 studies found less superficial infections in percutaneous repairs, presumably because of the smaller wound. And the study that did find that the other study that didn't find less superficial infection found a higher superficial infection rate. But for some reason, antibiotic prophylaxis wasn't used in that study. The studies did find a significantly less wound breakdown, healing delay complications in the percutaneous group also, presumably because of the smaller wound.